Welcome to this explainer. Look, if you or a loved one has ever had to face a glaucoma diagnosis, staring down that massive menu of surgical options can honestly be completely terrifying. It's overwhelming, right? Well, today we're diving into a truly fascinating medical landscape known as minimally invasive glaucoma surgery, or MIGS. We're going to take all of that intimidating medical jargon and organize it into a clear, easy-to-understand surgical toolbox. Let's explore exactly how these modern microscopic procedures are working right now to save vision.
Okay, so let's explicitly define what we actually mean when we say MIGS. Fundamentally, this entire concept is all about the eye's internal plumbing. You see, glaucoma is often driven by dangerously high pressure inside the eye, simply because fluid can't drain the way it's supposed to. Minimally invasive glaucoma surgery represents this incredibly modern wave of procedures designed to clear out or bypass that blocked plumbing, improving the outflow of fluid to relieve that pressure. And the real beauty of MIGS? It aims to do all of this without the massive incisions and higher risks that come with highly invasive traditional eye surgeries.
So here is our roadmap for today. First, the MIGS revolution. 2, canal-based drainage techniques. 3, subconjunctival and bleb surgeries. 4, lasers and superciliary outflow. And finally, managing devices and revisions.
All right, jumping right in with Section 1, the MIGS revolution.
A really major driving force behind demystifying these surgeries is the AG initiative, which is spearheaded by specialists like Dr. Constance Okike. AG stands for Advocates for Glaucoma Education, and it's his fantastic global effort to improve how we all think about interventional glaucoma strategies. What I absolutely love about this is how it empowers everyone, from surgical trainees learning the ropes right down to the patients themselves. It strips away the overwhelming medical jargon, which means the next time you or someone you know is sitting in that exam chair, you aren't just taking orders. You're actually making informed, confident choices about your own vision.
Moving on to Section 2, canal-based drainage techniques, and improving that outflow.
This part of our surgical toolbox focuses heavily on the eye's natural drainage pipe, which is known as Schlemm's canal. When that natural pathway gets clogged up, pressure builds. Now, surgeons use procedures with, frankly, intimidating names like goniotomy or trabeculectomy. But actually, those are really just microscopic techniques for opening up clogged tissue using tools like GAT or the Omni surgical system. Then there's canaloplasty, which uses viscodilation to gently stretch the canal open. Think of it literally like a micro-roto-rooter or a tiny balloon angioplasty, but for your eye. The goal here is simple. Physically clear out the natural blockages so the eye's original plumbing can just get back to doing its job.
But sometimes you don't just clear the canal. You actually need to prop it open with hardware. Dr. Okeke points out the differences between the iStent and the Hydrus. These are two highly specialized trabecular bypass stents. While they both sit in the exact same part of the eye to hold that drainage pathway open, they have completely different shapes and mechanisms. It's not one size fits all. The surgeon has to carefully evaluate the specific anatomy of the patient's eye to decide which tiny piece of hardware is going to provide the best, most sustainable drainage.
And we see a very similar decision-making process when looking at canaloplasty approaches. Surgeons don't just rely on one single tool. They have to weigh the unique dilation properties of different systems like Omni, iTrack, and Streamline. Each of these tools navigates and opens the canal just slightly differently. It really highlights how customized this interventional strategy has become today. The surgeon is quite literally mixing and matching these highly advanced tools to find the perfect anatomical fit for a patient's specific eye structure.
Section 3, subconjunctival and bleb surgeries.
Sometimes the best way forward is just a detour. Devices like the Zenus gel stent are designed to completely bypass the primary clogged system. By inserting this tiny gel-like tube, fluid is redirected from inside the eye to just under the conjunctiva, which is that clear membrane covering the white of your eye. This creates a tiny, highly controlled pocket of fluid called a bleb, and this bleb basically acts as a reservoir where the fluid can be naturally and safely absorbed right back into the body, effectively lowering the pressure inside the eye.
Now, another really major player in this blood-forming category is the PreserveFlow microshunt. Looking at extensive real-world data presentations from experts like Dr. Keith Barton, the PreserveFlow has emerged as incredibly reliable. When you're dealing with glaucoma, everyone is chasing one magic number, the target intraocular pressure, or IOP. And the real-world data shows that the PreserveFlow microshunt is remarkably consistent at helping patients effectively hit and, more importantly, maintain those crucial target eye pressures over the long haul.
I love this phrase, stinting to stop the tinting. It brilliantly illustrates Dr. Barton's mindset during a PreserveFlow insertion. This refers to a very specific, delicate part of the procedure. When placing these tiny shunts under the delicate tissues of the eye, surgeons absolutely have to ensure the tissue architecture remains exactly where it needs to be. They do not want the tissue tinting or pulling up unnaturally over the device. It is absolutely mind-blowing when you think about the micro-precision required here. It's not just about getting the device in, it's about perfect anatomical placement so the whole thing functions flawlessly.
Section 4. Lasers and supraciliary outflow. Exploring some alternative pathways.
Let's look at the lasers first. Options like ECP, which stands for endoscopic cyclophotocoagulation, and the micropulse laser offer entirely distinct mechanisms for managing this condition. Instead of implanting a physical stent or creating a new drain, these lasers actually target the tissues inside the eye that produce the fluid in the first place. So if previous surgeries were all about unclogging the drain, this approach is basically about slightly turning down the faucet. It's an incredibly elegant solution for controlling pressure without leaving any permanent hardware behind in the eye.
Alternatively, if a surgeon does want to use hardware but go a completely different route, they can tap into the supraciliary outflow pathway. This is essentially a deeper, alternative fluid highway sandwiched right between the layers of the eye's wall. Doing this involves an entirely different subcategory of devices, including tools like Cyclopan, CyPass, and AlloFlow. It just goes to show how many different, wildly inventive avenues brilliant medical engineers have found to solve the single problem of trapped fluid.
And finally, Section 5, Managing Devices and Revisions.
Look, the reality of literally any surgery is that things just don't always stay perfect forever, and human bodies change. Dr. Barton emphasizes that managing a failing bleb, where that fluid reservoir stops working efficiently, is simply an inevitable part of the process. Tissues heal, they scar, and sometimes flow gets restricted. But here's the thing, it is not a dead end. Managing these situations requires specialized surgical walkthroughs and revisions. This surgical toolbox isn't just for the very first operation. There are specific techniques entirely dedicated to rescuing and maintaining these outflow pathways over a patient's entire lifetime. Let's look at a really concrete example of troubleshooting the PreserFlow microshunt. Sometimes the problem actually isn't high pressure, it's the exact opposite. If a patient develops dangerously low eye pressure due to an inflammation like uveitis, surgeons can step in with what's called ab interno stenting. That basically means they work completely from the inside of the eye to throttle the flow of the microshunt, letting the pressure safely come back up to a normal level. Or, if absolutely necessary, they can use minimally invasive techniques to remove the shunt entirely. It's a highly adaptable system.
And sometimes, the absolute most effective revision requires stepping back from MIGS altogether. There are advanced revision scenarios where the absolute best course of action is removing the minimally invasive device to make way for a larger traditional tube implant. Knowing exactly when to pivot from a microshunt back to a traditional surgery is a vital skill. It proves that MIGS isn't about replacing traditional surgery entirely, it's really about having a vast array of options so the surgeon can safely escalate or de-escalate the intervention based strictly on what that patient's eye needs at that exact moment.
So, with this incredible, ever-expanding toolbox available from microstents and lasers to subconjunctival blebs, we are left to ask, which MIGS for which patient? As this technology rapidly evolves, how soon will your eye doctor be able to perfectly tailor a microscopic solution before you even notice your vision slipping? The science is moving incredibly fast, and the potential to save vision is better today than it ever has been. Thank you so much for joining me on this explainer. Stay curious about your health, and I'll see you next time.